Hi. One of the questions that I get asked a lot about is, do I use radio tracers in the operating room, and is intraoperative PTH necessary? So my answer is, I don't know why people use radio tracers in the operating room. It doesn't make any sense to me. Let me explain how it works. So that chemical is called technetium-99. It's the same chemical that's given for a sestamibi scan or a SPECT scan or a SPECT-CT scan. And what that does is it takes up in mitochondrial-rich organs in your body, your heart, your liver, salivary glands, the thyroid, parathyroid adenomas specifically, not normal parathyroid tissue. It does have some background uptake into a lot of tissue, but in general, the highest uptake is into those other organs. Okay, so what it's done is it's given preoperatively, and then during the surgery, you have a little probe that can be inserted into the incision and check the background ratings versus some specific tissue. Say there's a thyroid nodule that has high uptake of this, the number would be very high. A parathyroid adenoma should also be very high. My biggest issue with this device is that in order to use it in the way that people are using it for parathyroid surgery, you have to identify and find a parathyroid gland or a parathyroid adenoma first. And at that point, you've already done all the work. There isn't really an extra benefit to using that Geiger counter to measure the background levels. My impression is that anyone who does a lot of this surgery, in particular parathyroid surgery, should be able to identify a parathyroid adenoma versus a thyroid nodule versus normal parathyroid tissue. I'm not saying it's always easy. Many times it can be challenging. We have pathologists at our disposal to use for frozen sections to help differentiate sometimes between abnormal looking tissue and parathyroid glands. But the utility of radio tracer is few and far between, and I don't think is worth it on a routine basis. Now, when it comes to intraoperative PTHs, this is the only way that you know if you're cured before your surgery is over. When you go into the operating room, a baseline level should have been drawn or is drawn in the operating room. This gives you your starting point. Then we know that if we remove the hyperfunctional tissue, aka your parathyroid adenoma, your numbers should go back to normal within a couple of minutes. I've had numerous cases where I found 4 parathyroid glands in the neck. One of them could have been a parathyroid adenoma, and the levels don't drop. The other 3 glands are perfectly normal and not hyperplasia. I've gone looking around and found a 5th gland, which was a supernumerary adenoma in an ectopic location. It's not infrequent that this happens. Without intraoperative PTH levels, you would never have known that you cured the person. Then they would wake up, go to the recovery room, go home, have blood work later on to only find out they were never cured from their first surgery. Now going back into a reoperative neck is exceedingly difficult and presents with a lot of complications and potential problems. So yes, it's inconvenient to use intraoperative PTH in the operating room. It does take time. Even in the best setting, it takes 8 minutes. Other times it's about 25 minutes. That's wasted time while you're asleep and under anesthesia without any surgery being done. But it's the best chances of cure on your first surgery. And until we develop a better tool, I stand firmly behind it.